First of all, my name is Steve Oliphant. I just want to give a quick shout out to all the partners and legacy partners. First, I want to start off thanking Nikki Bucklew for Real Estate Institute. I also want to thank Abby Holiday and Company, represented by Tamara Singleton, Tana, and Angela McCants back there in the back. Also, legacy partners, Dallas Supreme Relocation with Steve Oliphant. That's me, Angela McCants, and Tiffany Gonzalez. I also want to thank the Senior Blue Book with Kathleen Wargoski. Hope I pronounced it. Okay, hope I got that right. And also want to thank the 50 Plus today with Leslie Fairland. Also consider it done with Tiffany Gonzalez and the North Texas Bank for their financial contributions. And also I want to thank the audience, you guys here as well. And I'm going to ask you guys, there are surveys on the table. We will ask you to fill those surveys out when the moderator and the panelists are through. You can feel free to ask any questions you guys have, okay? Thank you so much. Thanks for coming.
Missing a couple of people. Where are they? Good morning. I'm Angela. Can you hear me? I'm Angela McCants. Calming down. Okay. I'm a CSA with Dave Perry Miller, real estate, as he said. And as a real estate professional, we get invited to a couple of conversations, usually one with, okay, as a real estate professional, sorry, I'm still kind of trying to get everything together, that I specialize in helping retirees and longtime homeowners right size. After they've lived in their home for a long time, 50 years sometimes or more. And so, are you taking this? We're going to have to do it. We're typically involved with two kinds of conversations. One, where we're deciding to move now, where they're deciding to move now, and two, where they're deciding to move later. Rarely do we get invited to a conversation where they say, we're not ever going to move. They would not be asking a real estate agent for that conversation. But whatever the housing plans are, their main point is, they don't want to move, no one wants to move to a nursing home, ever. And two, they want to maintain independence at all costs. So whether you are, I'd like to give you a new mantra to consider. And it's this. I want to live my very best life, and I want to surround myself with people who can help me do that. What do you think about that? Would you repeat that after me? I want to live my very best life, and I want to surround myself with people who can help me do that. So this morning, that's exactly why we are here. We're going to meet people who help people stay healthy or get healthy and help them live their very best life. So would you please, the panelists, if you would come to the front here. And the rest of you, I'd like you to turn to your neighbor and say, I'm going to learn something new.
I'll sit at the end down here.
No, well.
All right.
No, don't make me feel like if Faye comes in, she'll sit here. All right. Yeah, this is my first time missing a panelist, so I'm like, but we're fine. She will cover her topic next month also, which is about paying for this. Paying for these kinds of things. Help. All right, so let's start off with giving your name, your company, and your background. Just a short synopsis.
So my name is Ashley Cottrell. I am the Director of Business Development with Healing Hands Healthcare. I'm also a nurse. However, I don't function as a nurse with this company, but we are a home health agency.
I'm Robbie McCullough, Certified Senior Advisor as well, and I own Assisting Hands Home Care license, PAS, Personal Assistance Service Agency in Texas, covering Dallas, Collin, Rockwall, and Kaufman County.
And I'm Angela Thomas. I'm the owner of Caring with Grace, and we are care managers. I'm a member of the Aging Life Care Association. We used to be called geriatric care managers. Anyway, and I've been in business 16 years, and I have a team. We're a team of 11 care managers, so families usually call us in times of crisis and transition.
Okay, thank you for that. We want to deal with some misconceptions today. And so let's clarify the differences between home health and care and what you do. So let's start out with you. What's the difference between these two kinds of companies?
Okay.
With that.
Well, with care management, families usually call us, like I said, at a time of crisis or transition. Occasionally, people will call us ahead of time, kind of like they might call you for we're going to move down the road.
Right.
So people, often it's the adult children that call us, and perhaps the parent has fallen, had a broken hip, they're in rehab, and what do we do when they come home? So we care managers connect people with services such as assisting hands or healing hands. And so families will call us to say, where's a good home health company to continue therapy for our loved one in their home. And then a lot of times families continue to need our help as time goes on. So some situations are short-term and some are long-term. And half my team are nurses. I'm also a nurse. And we take people to doctor's appointments and that type of thing. So we're more like the coach or the quarterback, and then we call in the players, and that's you guys.
Right.
How do people pay for yours?
We'll start with me.
Yeah.
We're all private pay. Some long-term care policies will cover our services on a limited basis, but most of the time we're private pay. And in Dallas, the going rate on an hourly basis for care managers is anywhere from $125 to $165 an hour.
Robbie?
So I use the analogy, we're a lot like the glue that holds this whole aging process together. So we're partners with the family between our caregiving team and our office to help families with Angela's coaching, general manager keep them safe and sound at home and age with dignity and grace. So we do we're not the sexy skill partner like Ashley. We do the real basics of life: ADL, baby dressing, transfer, cooking, cleaning, errands, all those little things that families need when they have someone declining, but just can't do it all on their own. So we are also 90% private pay. Long-term care pays for ours. The VA has a good program, pays for ours. Medicaid pays for ours. And now about 10-15% of Medicare Advantage plans are starting to pay for ours, which is very encouraging. Traditional Medicare probably take 10 more years. They're a little stodgy when it comes to services, but that's still, and almost everybody, our big challenge, a little bit like Angela's, is people know they need it. They just can't always afford it. So having a better insurance solution really helps families because they want to help them. So generally it goes back to the family first. That's a burden. So I bet you probably a third of my clients, it's just respite for that primary caregiver, whether it's the husband, wife, oldest daughter, whatever. Even if it's 1 or 2 days a week, that keeps them safe, sound, and sane, with that little extra help.
Ashley?
So on the skilled part, we're in an acute period in the patient's life where we're trying to transition them to get them back to their best functioning life. So if you've had a fall, or if they have some sort of exacerbation with COPD or CHF, we'll come in and we'll bring nurses in, physical therapy, occupational therapy. We also have speech therapy. And we're there to get them back on their feet. And so we work side by side. We're an extension of their primary care provider or their surgeon. And so what happens is we come in and they think we're staying long-term hours. And we're not long-term. Typically we're there for about an hour, 2 to 3 times per week. We do also offer home health aides that can come in and do baths, you know, two or three times a week. But what happens is when we get there, the family and the patient believes that we're staying long-term, and we can't stay long-term. That's when we reach out to these guys. And so he comes in, we partner with these home health or home care agencies, because they need to have somebody there to keep them safe while they're at home. So if they're using an assisted device to, you know, get throughout their home, and we're not there 24 hours, we can reach out to them, and they can make sure that the patient's safe. They're transitioning from the bed to the bedside commode, or if they need to, you know, transfer from the bed to the recliner, they're able to stay, you know, those longer hours. Now, the difference between the pay is we are covered by insurance. So typically we're covered at 100% by insurance. However, some of those Medicare Advantage plans, they may have a deductible, and we'll let the family know that up front. But a lot of what we do wouldn't be possible without the assistance of both of these people.
Awesome, thank you. Okay, so now we're going to go over some myths or truths. You will tell us. So the first one, caregiving tasks. Are they really hard on family members and friends? Is that true, or is that a myth?
Oh, they're very hard. You know, emotionally, physically, depending on the level of acuity for the patient or the family member, you know, especially as they begin to decline. A case I used that Angela referred to us, 3 or 4 years ago. Sweet doctor who was end-stage Parkinson's, totally bedridden, couldn't move at all, cognitively still super sharp, but we had 2 caregivers round the clock just to keep him safe and clean. So yes, it can be very damaging. At the beginning of a decline, maybe not so much, maybe more emotional than physical, right? But as they continue to decline, it's really tough on families, which is why respite care, or even just you know, 4 hours every other week really gives that primary caregiver a break. It's tough.
Some people may not know that term, respite.
Just break,
Help 'em.
time out,
Yeah, time out.
recess, whatever you want to use. We're fancy, we use respite.
Very good. Anything else? Did you all have anything
Well,
else to
I
add to
wanted to
that?
add that it does really depend on who the family caregiver is. If it's the spouse, you know, they're around the same age as the person that's declining, so they have their own health issues, and they can really burn out in the process of caregiving. Statistically, spousal caregivers often die before the person they're caring for. Family has no plan in place. Suddenly, mom went to sleep and didn't wake up, and dad is there with dementia by himself. So that's one thing to consider. And then the other one is, you know, an adult child that's trying to care, usually having to work also. So those are very challenging situations for families. And like Robbie said, you know, even short-time help. So I got a call from a son who moved his mother last year in with him, and of course she's declining. And he's taken his family medical leave, but it's about to expire. And so he's trying and paying a lot out of his own funds. He did not have a lot of money, you know, to get care so he can go back to work.
Right. And just to kind of illustrate that further, I asked my dad, okay, so my stepmom passed away in February of Alzheimer's. And we saw him, even though his health is pretty good, certainly relative to hers, saw him unbelievably decline because the emotional and the physical together, they were in a care home last year. And then she's passed and he's moved in with my sister, younger sister, and he's inclined again. So that dynamic of, even though they're in a group home, he was still a primary caregiver. The emotional and the physical of seeing someone decline really rough.
Amen to that.
Amen. I
I'm
know
just
you know
going to
that.
just go ahead and give you a shout out. During the pandemic, my mom was going through Alzheimer's, and she's such a social butterfly. So it was really hard for her to just see us, and then if we're working, I mean, it was just not good. So Robbie would send someone, and oh my goodness, she would go on and on about how wonderful, how lovely, and what a good time she had, you know, and she was just easily taken care of, and companionship was,
I think people
was-
really
I
underestimate.
can't say enough for
Yes.
it.
They really
Yeah,
do.
it'll bring a patient out of depression
No
if they have a
question.
good companion.
Yep.
Yeah.
And for our side, as far as the burden on the family, and what we'll typically see is husband or wife will try to transfer the patient, right? And so then they're at risk for hurting themselves. And so that's when we like to come in and do an education portion and teach them how to, you know, transfer safely. And if they're not physically able to, kind of have to sit them down and say, hey, if you get hurt, he's already hurt, we're in a worse situation than what we're already in. So then we'll reach out to Robbie and say, hey, we need to have somebody come in here and at least help throughout the day to transfer and things like that, to kind of take that burden off of the family or the husband or the wife.
Awesome, thank you. All right, how about this statement? All companies are equal. Like all realtors are equal, right?
She laughed harder, she
No.
should go first.
Okay,
So-
yeah, let's go with you, Ashley.
A lot of people don't understand how we get rated. So we are rated by our patients. And so Medicare sends out a survey at the end of treatment. So once we've already discharged the patients, they're going to receive a survey in the mail from Medicare. And by law, we can't help them fill out that survey. So they have to fill out that survey and mail it in. And whatever star rating we receive from 1 to 5, we're stuck with. And so we are a 5-star home health agency, and we've maintained that star rating the entire 6 years we've been in business. And so typically when I go and meet with the family, they'll say, I'm with an agency already, and I know they're a 1-star agency, but they tell me that doesn't matter. So my analogy has always been, go try to stay at a 1-star hotel and expect 5-star service. It just doesn't happen. So that star rating is very important, and it means a lot to us. We strive every single day to maintain that rating. And so no, not all agencies are created equally. And what we will do is, if we are not the best fit for you, so we don't have psych nurses, so if your patient has psych issues, we are not the best fit agency for you. We will find you an agency that is a best fit for you. Or if a patient has lymphedema and they need lymphedema treatment, we don't have somebody who's certified for that, but I know somebody who is, and I'll find you a great agency that can help with those specific needs. So the agencies are not created equally. Just to give you some highlights on Healing Hands, our turnover rate in 6 years is 3%. So patients that, you know, go off our services and then come back, they're able to call and say, hey, Heather was my nurse last time, could I get her again? Absolutely, you can get her again.
Thank you.
Yeah, so obviously they're not the same, but to Ashley's point, I subscribed 4 years to a third party, kind of like CMS. So CMS looks at us, you know, we're kind of here on the healthcare food chain. I said we've evolved from plankton to krill, so we're pretty proud of that. But we're a non-skilled service, so they don't rate us. But I voluntarily subjected myself to not every 2 years, but monthly reviews from Home Care Pulse, just an agency that does it. So every month, they call 4 to 5 clients and they rate us, okay? And that's not too frightening, because clients are usually pretty rational, and we know if they're mad, right? But they also call 4 or 5 caregivers, I've got like 60, something like that, and they rate us. That's a little frightening, because caregivers can say, what's the word I'm looking for? Anything, anytime, so you never know. But all that really means at the end of the day is we do everything we can to provide good care to our clients and take care of our caregivers. And it's a real balancing act. Recruiting's been, we were talking about this beforehand, really, really hard, and it's still tough, but it's way better than it was even 3 or 4 months ago. So we really try hard to give that care that we promise. Doesn't mean caregivers won't do something dumb, because they will. They'll no call, no show. That's never going to stop, unfortunately. But we'll try to fill somebody as soon as possible. But Home Care Pulse is our CMS equivalent, and there's only 2 or 3 that won the level that we wanted all it out, so we're really proud of that.
Okay, thanks, Rob.
Yeah, and you should be proud, Robbie.
Yeah.
Yeah. Home Care Pulse is considered the industry standard for evaluating home care companies, so I do know that. And as to us, I would say the quality of people who are members of the Aging Life Care Association is pretty consistent, okay, and high. In order to become a certified care manager, or they also accept other certifications from the CMSA, which is the Case Managers Society of America, and 2 other groups, we have a pretty high professional standard. So I feel like any care manager that you would call in the Dallas area is going to be very good. The only thing that sets me and my company, Caring with Grace, apart is we are the largest one. So, you know, I have 9 active care managers, and we usually assign 2 people to our cases, with one being the primary care manager, but we keep track of everybody that's on our roster so that if there's a need and the primary care manager can't be there, then one of our other team members can go. So that's the only, you know, difference, but I love my colleagues who have, you know, solo practices or 2 care manager practices, and it's really been a great fit for me, and I'm very proud of
So
Aging Life Care.
if a family does not have a care manager, is it usually the person in the family
Yes.
managing everything?
Yes, so, I mean,
And so-
and sometimes I have family members that call me and they say, I'm doing this for my mother, I'm doing that. You know, I'm like, well, you really don't need me because you're doing what I do, you know. But then there's so many other situations, especially adult children that live away. So right now I have a lady over at Presbyterian Hospital, and, you know, one daughter lives in Houston, one in Atlanta. There's nobody here in Dallas, and I'm checking on her, talking to the doctors, making sure that we're progressing, you know, the way we need to for her sake, and, you know, the daughters, I think, really appreciate that.
When family members do this care management piece, what's the short side of it? What's the,
Oh, I mean, it's very
downside?
time consuming, you know, and I tell people it's my job, right? So the difference between, and you asked me to share this story, I started out when we moved here to Dallas 21 years ago as a family caregiver. So my husband's aunt moved in with us. We kind of knew she needed a little help. We had no idea that she had Alzheimer's, but we, you know, within 4 to 6 weeks, we were like, something's going on here. And over the next year, you know, I took her to the doctors, and she got the diagnosis, and we started on some medicine. But I had teenage children at home as well, and it really became obvious that it was not a long-term solution. So she did move to an assisted living, and she had enough money to do that for about 4 years, and then ended up, you know, having to go to a Medicaid skilled nursing, which for her, it was a good experience. It's not always that way. But I was acting as her care manager. And so in the process of those 7 years, I met a care manager, and I was like, well, what do you do, you know? And she was from an LPC background, licensed professional counseling background, but she'd been doing care management since the early 1990s, and now this was 2004. So she was kind enough to meet with me on a monthly basis and really mentor me. So most people that do care management have come from some other clinical background. You know, I have a speech and language therapist on my team who does care management. And, you know, we do everything from soup to nuts. So I've had some pretty interesting experiences. I'll probably write a book at some point. You know, when I'm sitting in a vet's office with a cat with mange, I'm like, well, people just wouldn't believe what you can do or will do, you know. So we've had a lot of fun experiences, but, you know, for a family member, that can become very taxing, and especially if they're still trying to work.
Right.
That's the big one, and that's been a big change in the last 30, 40 years, right? I mean, before you think of our mothers, you know, and when our grandparents or great-grandparents got sick, well, you know, they just took care of it because they were homemakers and they were available, and there's still people like that, but it's, you know, it's not really the case anymore.
thank you. All right, the next one is, people have freedom of choice concerning which agency to use.
So that's absolutely true. You have a right to pick whichever agency you would like. And so we educate the family and tell them you should be going to Medicare.gov and checking the agency when they recommend an agency to you, whether that's a hospital or a rehab facility or even an assisted living facility, because some of those facilities will have a home health agency inside their building. Now, that doesn't necessarily mean that's the best agency, that's just the agency they have available for that patient. So you should go in, check the ratings, and make sure that you're getting a good agency. I'm trying to think if I have anything else to add on to that.
What if it's not in your network?
So if it's not in your network, we can still take you on. You'll just have, a copay to pay to us. But if we're not in your network, we can always recommend an agency that is in your network. Depending on what your deductible is, you may want to go with an in-network provider. However, in some of these rural towns, you may not have an agency that's in your network, so you may have to go with an out-of-network provider. And at that point, you want to pick the best agency. If you're going to have to pay for it, you might as well pick the best agency because, that's going to be your biggest bet there. So we always just say, as far as insurances, you can look at the insurance plan. We have a medical case manager on staff, and we can look at the insurance plan and make sure you're on the best plan for your needs. If you're not, we can help you to get that plan switched over.
Yours is probably the most complicated.
Yeah.
Because there's so many insurance, especially since Medicare Advantage are now almost 50% of seniors. 20 years ago it was 0. I've got my insurance Medicare Advantage guru in the back. So, but yeah, so that makes it more complicated. On my side, it's a lot more simple because it is private pay. And we've actually had clients that we've shared with other agencies because during COVID especially, when staffing was so restricted. It might take 2 agencies to take care of someone like that. We have no problem with that. So, but they certainly have freedom of choice. But your question about if you go into a community, and I'm going to try to say this as politically correct as I can, communities are great partners of ours, but they also have their own agenda. You need a third party like Angela who's going to give you the honest truth on. They're going to tell you what they want you to know, and that's about it. And they have their own proprietary or sponsored home health, hospice, maybe even home care in their community. And they don't come right out and tell you that you have freedom of choice. So you need to know that, and your patients. It's really powerful.
Yeah. So when you go to a hospital, I'm sorry to cut you off, but if you go to a hospital or rehab, they're going to give you a list when you discharge. A case manager should come see you and say, hey, here's a list of home health agencies. Now, they can't technically, point one out, but they are supposed to educate you on the best agency. That list is supposed to be provided for you. However, not all agencies can be on that list. The last time I checked, there were 1,600 home health agencies registered in Dallas. So when you look at that list, how often are they going through that list? So you want to do your research prior to going in or prior to helping a family member out so that you can pick an agency, because the best agency may not even be on that list. And how we get on that list is with my team and the marketers. We're going in there and we're asking them to add us onto that list. We don't get to see the list, so we don't know if we're actually on the list. It's just when patients reach out to us and we try to ask them, how did you hear about us? And occasionally they'll say we were provided with a list from the case manager there at the hospital. But then again, they have their preferred agencies through the hospital as well.
So for the skill side, CMS for sure is your first stop for hospice and home health. On my side, I would make the argument certainly home care pulse, because if there's 1,600 home health, I haven't done the count, it's got to be 2,000 home care agencies like us, right? Because the barriers of entry are pretty low, to be transparent with you. But only maybe 5 or 10% are crazy enough like me to subject themselves to monthly critiques and reviews of your own clients. So that's going to eliminate 90% of people who don't want to do that. Because you have to be a little wacky to do that, because you don't have to do that at all.
Yeah.
So that's going to tell you a lot. They're willing to do this. Then look at the scores on that, where CMS is required, ours is voluntary, and that's going to tell you a lot. That's my side.
I'm thinking about the people who are on Medicaid and they need extra help. Usually most of you all are private pay.
Correct.
So what are their choices?
On my side, it's pretty. There are Medicaid agencies that work with Medicaid. I don't personally use that, but I know 3 or 4 that do that. And that's their primary marketing source, so they're pretty good at it.
So you would have
I
high
refer to them.
scores?
I would,
Would they have high scores?
they're probably
also?
not going to subject to theirs on their pulse, but they would be able to accept Medicaid. I'm actually working on a Medicaid dual qualified candidate, McKinney, where I think it's Medicaid and maybe has some Medicare Advantage, but if they're on Medicaid, they're on there for a reason. They don't have assets to be able to pay for private pay. But I can refer them to a Medicaid qualified agency that will help them get the care they need. Yeah.
And did you say you had someone here that?
Oh, he's the
Medicaid,
Medicare guru of all
Medicare
time. Right there.
Oh, is it really?
He always,
Because you need to,
he
that
knows
was who
everything
I
about
had in that
Medicare.
seat, so if you want to join
He's
us.
very shy.
We may
I don't
have
wanna
some
worry about
questions
your
for
operation,
you.
not shy. You keep it going, I'm
Okay.
here in the back. Thank you.
So you were asking about choice. So it's for care management, yes, you know, it's completely the family's choice and the person's choice. What I will say about the Dallas market, Robbie and Ashley are correct. Actually, it is the most saturated market in the country with home care and home health companies. So sometimes I'll get calls from people, you know, from another state saying, well, I'm moving to Texas and I'm opening a home care company. I'm like, you really should check that out because, you know, first of all, the pipeline is limited and there are so many companies. So to just be aware of that, it's really is a saturated market. And for care management, maybe not so much. You know, there's about 7 or 8 agencies that do care management. Certainly you have your choice. The nice thing that I like to say about our group that are members of the Aging Life Care Association is we're very collegial, we're very professional and supportive of each other. So we have a closed Google group that we can put in. Who are you using now for home health or home care? Has anybody used Robbie recently or whatever? And also about communities and skilled nursing or rehabs. So we do support one another because there's a lot of resources out there, but it's hard to keep track of everything and the most recent, you know, what's going on at this rehab, because I haven't had somebody there in 3 years. So I can email my colleagues and say, has anybody had somebody at this rehab? And they'll go, oh yeah, great experience. And so that's, I say if you hire one of us, you hire all of us, because we want to give good service and we want our clients to, you know, have what they need to age well, to do exactly what you were saying at the beginning, which is, you know, to age as best life.
But I guess with so many out there, if someone did find someone they thought was good, how would they check it out again? How would
Now,
they
you
check
mean-
out that agency or
Well, I mean, like Robbie said, I think going to Home Care Pulse is a great
Home
thing.
Care Pulse?
And it's,
And is that homecarepulse.com?
Yep.
Yeah.
And for our ratings, you can go to Medicare.gov and see those ratings.
Medicare.gov?
Mhm.
Okay, good.
I mean, my company's rated on the Better Business Bureau website, but, you know, I mean, if care managers are a member of the Aging Life Care Association, that's a high standard, so you can feel confident. And the nice thing too, you know, we're all over the country. So I've helped a lot of families move their loved ones from another place to Dallas and move their loved one to where they live. And so we usually cooperate or, you know, work collegially with other care managers in other states to make sure that, you know, the senior, again, has the best quality of life they can.
I'm going to ask one more question and then I'm going to open it up for the audience. Caution should be used if hiring a private caregiver not affiliated with an agency, a licensed agency.
Yeah, definitely agree with that statement. It's because people like Robbie, they do background checks, the caregivers are trained, they get ongoing training. Also, if a caregiver, like you mentioned earlier, may not make their shift, you have, you know, somebody in the office, his team, working very quickly to get a replacement person. And usually the caregiver that's there at night doesn't leave until the replacement comes. I mean, that can't happen all the time. I mean, one of the challenges is a lot of the caregivers are, you know, mothers, got kids in school, you know, kids are in daycare, whatever. But, you know, you have a team in a licensed agency like his that are working to provide the caregivers and keep seniors safe.
Yeah, in addition to that, the backup plan is obviously a big deal, but and families certainly absolutely have a right to do that. But when they do, the thing they don't factor in is they become the employer.
Yes.
And they're fully responsible as an employer, like an agency owner with an owner. So anything that goes wrong with that home, they're responsible for it. All liability, if something happens to the family member, whatever, right? And all the tax liability and all those other things. So they become the employer, which is a huge burden. You know, so people underestimate that. Now, some people with all the money in the world on park don't care.
So if the
But,
caregiver gets hurt,
that's
Yeah.
the family, they might not tell that, but legally, if the caregiver got sideways, they have rights as employees. They become the employee, whether it's 1099 or W-2, of that family. And that's a huge responsibility.
Yeah, and the taxes and
The
all,
taxes,
very,
and
very,
they can't run for office.
Yeah.
That's a whole other story. We're all
yeah,
gonna get that
if
joke.
they
don't
hire
pay them
some, that's right.
okay, awesome. So what questions do we have from the audience?
I have a question for you, Angela. So if you have a patient who is in a hospital, how do the case managers within the hospital receive your services?
Well, they're usually very appreciative. You know, I say, I'm a care manager, I'm working to make sure this is a safe discharge for this patient. And they're like, great, you know, knowing that somebody's going to be following them then when they get home. And of course, the whole issue with Medicare and hospital readmissions, I mean, we're making sure the medications are picked up, the pill boxes are full. You know, that the person is, if they don't need care or not much care at home, that we're providing the level of support that they need. So yeah, the case managers appreciate us. I mean, we don't go in there to do their job for them. We want them to do their job, you know. We want them to give us that list of either facilities or agencies for, you know, continued home care or home health care. And then we'll bring in people like Robbie for the home care piece.
Is it true that your services, all your services can be used whether someone lives at home or whether they live in a senior living community?
Yep.
Yeah. We do a lot of events at assisted living facilities, and I'll tell you the number one complaint that I'll hear from a lot of those residents is I should have come sooner. I should have left my home and come here sooner, because they have such a community lifestyle around there. They're out of their apartments, and they have an activities director inside there that's pulling them out constantly, bringing them into the community. They do a ton of events throughout the days, and so that is really one of the big complaints is we should have just come here a lot sooner, sold our house and moved in. And a lot of them are 55 and older now. They're not 65 and older. They've dropped it down. Yeah.
I think as an industry, we've got to get better at sharing how important companionship and removing isolation from anybody, especially during COVID. It's easy to kind of forget that. You think about all the high-level skilled services, but man, the isolation, there's this survey came out during COVID that isolation for a senior is as bad as smoking 3 packs of cigarettes a day. Think about that, health-wise.
Yeah. Oh, yeah, absolutely.
So even just a safety check, you know, whatever come by once a week, make sure they have groceries, whatever, is really valuable.
And I think the families with the memory care situation have the hardest time, you know, navigating that payment situation. I mean, does anyone know what the percentage is in terms of how many people have long-term?
Ooh, it's about 8-9%. They're close.
What did
About
you say?
8%.
About 8 to 9% of the U.S. population.
Has long-term care insurance. Yeah, it's
not much.
pretty small. And the other thing that we spend a lot of time on, every one of those policies is different.
Totally different.
Oh, my goodness, yeah, I mean, if you're having to fulfill what the long-term care policy wants, but yeah, people don't understand, you know, one, how to activate the policy, and a lot of times they'll call us and they're like, well, we're saving that. We're like, no. You're spending that. If you need any help, we're going to activate that policy, and yes, your loved one's going to qualify under the different parameters that they have, and because you want to spend that money first Then if that money's gone, then you can start spending your own money.
Right.
Try not to spend your own
I
money.
think that happened a lot. I don't understand the dynamic of it. Unless they're on the board of directors for,
Well, I guess people
Genworth.
think they're gonna live to 100, which of
Yeah.
course is possible. That was my
Yeah.
own dad, but he did die at 95, you know. But people think, you know, I gotta save it for the rainy day, and I go in there and tell them, today's the rainy day.
It's raining
Let's
today.
get it, let's get it going here, you know.
So it does help to be.
Yes.
You can have a
I have a
question.
question for you. So how do you actually find, like,
Us, yes. Okay, so people find us in probably 3 different ways. One, people like Robbie, or maybe Ashley, now that I've met her, might say to the family, especially again if they live out of town, you might benefit from a care manager overseeing your parents' situation. And so the way they find us is going to the national website, which is aginglifecare.org. And so we are a professional organization, we had been called the National Association of Geriatric Care Managers. And about 8-9 years ago, because the term care manager was not trademarked or registered, we had to think of a different name for ourselves. So we did a large focus group all around the country, and the person we had hired came up with the name Aging Life Care Association. I didn't like it at first, I'll be honest. I said, oh, just take the word geriatric out, you know. But I've really grown to love it because we also work with disabled adults. That's a big, you know, people who have MS. I mean, we have a whole contract with the MS Society where we support people with MS. That's a nonprofit. We work with intellectually disabled adults as they age, so that's a whole different population. And then, you know, people who have had strokes. I mean, one of my longest term clients had a stroke at 35. She's now 58. Now, I haven't been caring for her the whole time, but the last 10 years I have been. And, you know, so everybody's story is different, and then there's a lot of similarities.
Any other questions?
I have a question. Angela, this is a question for you. So when you reach out to a home care team or a home health team, when the nurses or the caregivers need to communicate something to the families in regards to the client or the patient, are you that point of contact?
Yes, often we are that point of contact. You know, after the PT has seen the person and, you know, they're, again, you know, the families pay us to kind of take some of that burden off of them. But, you know, they might call and say, well, I think we've only got 3 sessions left. And then I may be thinking, well, I'd really like that person, even though they don't qualify for Medicare to pay for it or their private insurance, to continue getting therapy to maintain what you all have helped them gain. So we will also recommend to the family hiring private PTs, and I heard that you guys also provide that. So that's a resource to me now, because there's not a lot of private PTs out there. But it really can make a huge difference, especially for seniors that do have mobility issues. And, you know, once you get them up and walking, you don't want them to kind of lose that and have a second fall. I mean, we help Medicare a lot because we're all about staying at home, not getting readmitted to the hospital, all that sort of stuff.
Tell us about communication with the families. How do each of you navigate communication, especially if it's more than one child?
So I would say with the caregiver side, typically they're reaching out to us because they're in the home longer hours, and so they notice things quicker. So they'll reach out to us and say, hey, we noticed there's maybe like a decline going on or maybe a UTI coming on. So they'll reach out to us, so we correlate together to make sure that we're keeping that patient out of the hospital. So we're able to get in there. As soon as they notice something, they're reaching out to us, even if it's a small, like, we've had caregivers reach out to us and say, there's a little red area that's growing kind of on her, you know, back. Okay, then we need to get out there. We need to make sure we start some treatment on that before it turns into a bigger wound. But they notice those things and reach out to us. We have to be in constant communication with one another because we work side by side for that one patient.
So the patient, if they're not cognitively strong, who are you communicating with?
We're communicating directly with each other.
No, like which child, if they don't have a care manager, because about not that many people have care managers.
So we have to relay that information back to the primary care provider. So we give them any updates that's going on with the patient. We'll send them communication notes if we notice something's changed in their care plan. We're reaching out to the primary
So
care
you talk
provider.
to the doctor
Mhm.
directly. What
Yes.
about you?
Ours is more family-based since we're on skills, so we have, I think, a really great feature inside of our record-keeping platform called ClearCare, called the Family Room. I think my second or third client ever was a young lady, mid-30s, in Preston Hollow, whose dad just got diagnosed with Alzheimer's, but she just moved to New Zealand. So she was worried about staying in touch, just like you're talking about. So this family room, we can communicate, send messages, any time of day, night, we get notified, emails and texts, pay your bills, whatever it is, to that one platform. Multiple family members can do the same thing. So every case is a little different. Some family, there's one primary caregiver, some there's five, generally one guy will do the financial, somebody else will do the medical, somebody will do this, the errand. So just kind of depends on the dynamics, but we have the ability to kind of coordinate that either way. But the family room's really a nice little benefit to keep people connected.
Which is electronic.
Yeah.
Electronic,
Okay.
yeah.
And do the families, do they see the care notes like from the caregivers? That's one of the big pluses.
Yeah.
And yes, you do, I'm glad I didn't
Yes,
realize
we
you
did.
had clear
Yes,
notes,
we
yeah.
did. Yep, we did.
It's, so that gives people a sense. I mean, for me, we actually, I've been in business 16 years. I've seen the growth of technology. Technology is my third language, so it's not easy, but it is very helpful. So we have several, which I've been kind of looking at, cheating here, group text with family members. So there's 3 adult children. The caregivers just do a quick end of shift summary, or I have one of my care managers who visits a lady at Career Haven Court, some of you are familiar with them, twice a week. And before she goes in, she's texting the 3 children, and I'm on that text thread. Would you like me to facilitate a FaceTime? And the child that lives up in Boston says, yeah, great. Daughter lives in Austin. That lady went from her home with some care in there, but she kept throwing the caregivers out, which was really, really tough. They'd sit out in the driveway in their car, but anyway, she actually had a pretty, after initial, we knew it was going to be rough, she settled into the memory care and just is doing beautifully. And we were able to coach the family through that. It took us about 4 months to say, she's going to be okay. Let us help you for now. Let's get care in the home. But then, and thankfully it did turn out as we thought it would, and she's just so happy. So if I want to feel happy, I'll go up there and say hi to that lady because she's smiling and
Yeah. Awesome.
Well, I have another question.
Sure.
And this is for Ashley and Angela.
okay.
Because I know for most unskilled that they're not allowed to deal with medications that much. Yeah.
It's charcoal gray, but yes.
Yeah, I know. So for y'all, how do you deal with like the medication piece? Because I heard you mentioning, one of y'all mentioned about getting the pill boxes and that kind of thing ready. And from my understanding with home health care, that's not an ongoing thing, that may end at certain times, but for you, is that would be an ongoing?
Yes, we do pill boxes for a lot of people, because when they have skilled care coming in, the PT, OT, and all, then the nurse that sees them once a week can fill those pill boxes. So sometimes we'll have clients, we've been filling the pill boxes for a couple of years, but we'll back off because why not get Medicare to pay for that service? Yeah. And then 6 to 8 weeks when that's up, then we pick it up again. So yeah, pill boxes are a huge thing, keeping people taking their medications correctly and safely. So we use some automated things. If they have care in the home, then the caregivers present the medication, and hopefully the person takes it without too much difficulty.
So for our side, the nurse is going to go in when they do a start of care, and their goal is to get the patient refills all in one cycle. So they're going to work with the primary care provider to get everything on one refill, or 3 months, 6 months, whatever the insurance will allow us at that point. So they're going to fill those pill boxes for them, whether it's just a daily or a daily and nightly, and we provide those pill boxes to the patients. And as an added service, we're also going to give them a 2-week supply that we keep in a security box just in case there's an emergency. They have that backup amount of medication for them. But we can go in doing just as little as med management, and so typically those patients are on at least 5 medications, and we can routinely go in there and fill those pill boxes for them.
Are there any questions that people should ask but don't?
As far as home health services, if you have a loved one that you're entertaining home health services, so how they qualify, let's go over that. So how do you qualify for home health service? So in order to qualify for our services, you have to have the need for an assisted device, whether that's a wheelchair, walker, cane, crutches, or if you need the assistance from somebody else to leave your home. If it's a burden on you or a family member to leave your home, you're going to qualify for home health services. And so usually what we see is patients will call us and family's been taking care of them, taking them into appointments, taking them in to get labs, taking them in to get diagnostic imaging done. When we can do that in the comfort of your home. We can do labs inside the home, we can do diagnostic imaging inside the home, and so it's usually an education portion of what we can do, and then people don't realize it's covered under insurance. So when we come in, it's like a fresh breath of air, because it's like you've been doing all these things and we could be doing them for you. And so, and even on the provider side, we have to go and educate the doctors and let them know, we can do this, we can take this off the family. Instead of just sending them to the emergency room because their glucose level is high, we can come in and hang a bag, we can keep them home. That way they're not having to find a family member to take them to and from the hospital. Somebody's then missing work. We can come in and just take care of that for the family. So when we see those issues arise, we're usually just, educating the family or educating the provider.
Awesome, thanks.
On my side, the same thing. I would ask, like a home care pulse, or ask, and marketers are great, but, ask to talk to the owner, like Angela was on our agency. And that's a big deal, because I think 89% of the owners aren't involved. Their owners are very involved in the business. So, and I think that's really important, because culture is really important in the organization, especially in something so important and personal as home care.
Very good.
Yeah.
Thank you. Awesome, well,
I'm sorry, I have another question, and this is actually for you.
I got one.
How do you encourage or not you, maybe the people, your workers, how do you encourage the parents or the people that are needing your services to realize that they need to ask the caregivers? Does that make sense?
They need to what?
Ask the caregivers for the help. Like, for example,
That
my
is a hard
parents,
one,
I'm dealing
honestly.
with that right now
Yeah.
because my parents have caregivers, and it's great when I'm not there, but when I show up as Patrice, and I'm like, no.
Right.
do that. And I'm trying to figure out how to encourage my parents to make sure that they're working for y'all to help y'all and that kind of thing. So I need some tips.
And that's really maybe one of the hard, besides recruiting, that's probably one of the hardest things we have to do, because we know they need the care, the assistance, but I feel like especially that World War II generation, man, they're so resistant to admitting they need care. And once you recognize that and can admit that, then things usually go pretty well. But we get so many families that maybe 5 minutes in, they quit because and it's all emotional. They know they need the care, but they just can't accept that they need that. So once you get over that, then it's a little more coachable. But I can't tell you, I've ever had 50 shifts where the kids knew mom, dad, and grandma needed it, but they just couldn't accept it. I mean, and that's so unfortunately what I think has to happen, which is really sad, something bad's got to happen.
Yeah.
They got to fall, they got to
Crisis.
wander, elope out the house, something bad will happen, a crisis will happen. Then it's, I don't say it's too late, but then it's way harder. So, but unfortunately, that's the litmus that usually makes something like that, where they say, okay, now I know I need help. So, I know I didn't really directly answer your question, because it's hard.
Well,
And there's
I
not-
have a question for you, Patrice. What are they asking you when you come over to visit
That's a
to
good one.
do?
And it's really just my dad. I think it's a whole gender thing. So I don't think it is not my mom.
Yeah.
But it's just like the stuff that I know that they typically ask the caregivers when I'm not there. It could be something as, can you plug up my phone, my cell phone? Like something that simple. Oh, it's cold. can you get the heater? You know, it's those little things. And so I'm constantly reminding my dad, Mom's good. I'm constantly reminding my dad, when I'm not here, what are you gonna do? And I typically go, my parents aren't in Dallas, so I go to see them. And so I'm typically trying to remind him to do that, to ask them, because when I go home, I still have the caregivers there, just because I'm still trying to get my parents used to them.
Yeah.
But it's like automatically reverts back
Yeah.
to me. So.
Well, that may be hard to break him of that habit, you know, because he's, and it may be too that he's kind of reaching out for connection in some way by, you know, asking you to do something for him that maybe the caregiver would be doing when you're not
It's
there.
even hard on our end. Sometimes we'll go out there to do a start of care, we'll send a nurse out there, and then the patient will say, oh, I don't need y'all. I
Oh,
don't need
yes.
your services. I'm
Even though you're free, they'll still want to try.
totally capable of taking care of myself. And so usually once we have that conversation and let them know, this is something that your doctor has ordered. They want us to be in here. We're an extension of their office to lay eyes on you. So usually it's having that conversation with them and saying that we notice that it's a necessary need for you. And usually once we get in there and do that start of care and they, you know, start a relationship with that nurse and that care manager, then they realize, oh, I did need this service. And then, you know, they're asking for all the services at that point. They want to see what all we can do, what all we're capable of doing. So it's really a lot of education for us.
Yes.
Awesome.
I'm sorry. You know,
We're gonna get to do one-on-ones now, but,
That's
right?
one quick
Okay.
question. I'm sorry. Well, and it's just when you were talking about the lab works and that type of thing, how does that connection actually happen? Because I know that if the primary care physician doesn't necessarily know, or the other doctors don't necessarily know that they're getting the home health care, is that a piece where we connect them, or I hope that makes sense.
So the doctor shouldn't ever be out of the loop. They should not be aware that we're drawing labs. We cannot draw labs without an order. So if the nurses go in and they realize, hey, I think this patient might be having a UTI, or you know, there may be an infection coming on, we automatically have to reach out to the primary care provider, ask for that lab order, and then we have an online system that will send the lab orders direct, or the report directly to the provider. Then we wait for his recommendations. So if he wants to start him on an antibiotic, or if he wants to do an IV bag, then he'll reach out to us and let us know what's necessary. But yeah, we can't do any labs without that information.
I would say too, just as an addition to that, because she's absolutely right, is maybe your parents are going to see a cardiologist, or you know, or the cardiologist wants lab work, but the primary doesn't know that. So you know, part of it is the home health letting you know that's a service we provide. So if your parents, if any doctor orders labs, then let us know. You know, have them send us the order, because we can just go out to the house. And I mean, taking people in and out of cars, anything you can do at home is so much better.
Yeah, especially like for those Alzheimer's patients. Leaving their home and going to a different facility can send them into a tailspin. So we always have to go and talk to the provider and say, yeah, we understand you have your own lab inside your office, but it makes no sense for this patient to leave their safe environment when we can just do this in the
5
comfort
minutes,
of
10
their home.
minutes, and
Yeah, and so on that, as far as providers, if a patient has multiple disciplines on there, if they have, you know, a cardiovascular surgeon, or if they have orthopedics, whoever's involved in that care, we get all that information at start of care. Because we want to make sure if we titrate a medication that the cardiologist is aware that the PCB changed the medication. That way they're all involved in that.
Awesome. How many of you learned something new today? Show of hands.
yeah.
Let's give them a
I
big
did.
hand.